Hello, I'm Ashley Halderman, and I am an assistant professor in rhinology and skull-base surgery at the University of Texas Southwestern. Today I will be presenting a case and a review of SMARCB1 INI-1 deficient sinonasal carcinoma. We'll start with the case presentation and then review subtypes of SNUC and their estimated prevalence. We'll go over the pathology, histology, and immunohistochemistry, as well as the function of SMARCB1. Then we'll review the treatment, outcomes, and survival, and go over some key points and future directions. Starting with the case presentation, a 62-year-old male presented with several months of right nasal obstruction, epiphora, and headaches. He was a former smoker and had no other pertinent medical history. On exam, his extraocular movements were intact. He did have tearing from the right eye, but otherwise his cranial nerves were intact and symmetric bilaterally. And on palpation, he did have bilateral lymphadenopathy. Rigid endoscopy demonstrated tumor along the left septum, which was extending into the left middle turbinate as shown in this picture. Additionally, masses along the right mid-septum, possibly representing submucosal tumor spread, were visualized. CT scan showed a mass within the right nasal cavity with erosion of the anterior ethmoid cells, expansion of the nasolacrimal duct, and extension into the medial right orbit. There was thinning of the fovea ethmoidalis and lateral lamella on the right, with areas of apparent osseous dehiscence and intracranial extension. MRI demonstrated a multilobulated enhancing mass involving the right greater than left superior nasal fossa, with evidence for involvement of the nasal septum and extension into the floor of the anterior cranial fossa, with mass effect on the right gyrus rectus and orbital gyrus without vasogenic edema. There was no involvement of the tissues of the orbit or extraocular muscles, but there was involvement of the nasolacrimal duct. A biopsy was done in clinic, and the pathology showed a basaloid histologic pattern with nests of basophilic cells with a high nuclear to cytoplasmic ratio growing in a desmoplastic stroma. The tumor cells on immunohistochemistry demonstrated a complete loss of SMARCB1 INI-1, which was retained within the normal stromal background cells. PET-CT showed an FDG-avid sinonasal mass and bilateral FDG-avid cervical lymph nodes with no evidence of distant metastasis. The patient was staged as a T4B into CM0, and multidisciplinary tumor board recommended surgery followed by chemoradiation. The patient underwent an endoscopic anterior skull-base resection, and gross total resection was achieved. In addition, he had a right dacryocystectomy. The skull base was reconstructed with Duragen and an endoscopic pericranial flap. Bilateral neck dissections were also performed, with several nodes positive in the bilateral necks and in the left retropharyngeal region. The right neck showed extranodal extension in all levels except for level 4. The patient was then treated with adjuvant chemoradiation. The primary site received 66 gray, as well as the levels of the neck with extranodal extension, whereas the levels of the neck without extranodal extension received 60 gray, and concomitant cisplatin was given weekly for 6 doses. The patient is currently more than 24 months out from treatment and is alive with no evidence of disease. Sinonasal undifferentiated carcinoma, or SNUC, was historically thought to account for 3 to 5% of sinonasal carcinomas. Recent advances in immunophenotyping of SNUCs has enabled for further subtyping based on the genetic and expressive aberrations. And we've come to find that what we used to think of as SNUC actually represents a heterogeneous group of tumors with several new subclassifications, including genuine SNUC, which show IDH2 mutations and are thought to account for 49 to 82% of those tumors formally diagnosed as SNUC, nut midline carcinoma, HPV-related SNUC, SMARCB1 or an INI-1 deficient carcinoma, which represents around 14% of previously diagnosed SNUC, SMARCA4, and adamantinoma like Ewing family tumor. This is a flowchart which nicely summarizes the differential diagnostic workup of poorly differentiated sinonasal carcinomas, which has become quite involved given the description of several new entities. Focusing on SMARCB1 pathology histology, this tumor shows infiltrative margins, often with spread into the epithelium in a pagetoid manner. The surface epithelium always lacks conventional squamous dysplasia or carcinoma in situ. It shows cellular monotony, monomorphic small to medium-sized rounded nuclei with dispersed chromatin, high mitotic rates, necrosis, and has architectural subtypes, most commonly basaloid, followed by plasmacytoid, with some other rarer variants also described. On immunohistochemistry, the tumor cells show a complete loss of SMARCB1, which is retained in the normal strobal background cells. In sinonasal tumors, this loss of SMARCB1 represents a distinctive neoplasm. It is not a transformation from a previously well-differentiated neoplasm, nor does it show squamous differentiation. It is negative for NUT, does not harbor either HPV or EBV, and is not seen in well-differentiated or well-defined carcinomas. SMARCB1 is an essential component of the SWI-SNF complex. This complex is responsible for several key functions, including regulation of cell differentiation, cell cycle control, and apoptosis. The SMARCB1 gene acts as a tumor suppressor. Its absence alters the SWI-SNF complex function and leads to increased EZH2 activity, which in turn upregulates oncogenic pathways and suppresses tumor suppressor gene transcription. It is located on chromosome 22q11.23 and is a defining diagnostic feature in actually a variety of neoplasms outside of the sinonasal tract. These include malignant or atypical teratoid or rhabdoid tumors of childhood, epithelioid sarcoma, and epithelial tumor entities in adults and the elderly. Again, it is the primary and sole driver genetic event in these tumors. As this rare entity was first described in 2014, the literature on SMARCB1 deficient sinonasal carcinomas is quite limited. This systematic review and pooled analysis from Lee et al. Is the largest to date with an N of 128 patients. The results of this study suggest that the clinical characteristics of SMARCB1 deficient sinonasal carcinoma closely mirror those of historic SNUC. The median age is around 53, and there is a predilection for the male sex. The majority of patients present in later stages, and nodal metastases are fairly rare, with about 6% of patients in this study presenting with nodal disease. Additionally, around 6% of patients presented with metastatic disease. Due to the limited amount of information in the literature, not much is known about the optimal treatment for this disease process. Looking at the results of the systematic review by Lee et al., we can see that radical resection or surgery was performed in about 2/3 of patients. Induction treatment was not used very frequently, with only 20% of patients receiving induction treatment versus 68% who did not. And it's important to note that around 12% of their patients' treatment could not be determined. Adjuvant treatment was used more commonly in 56% of patients, and multimodal treatment was received in 75% of patients versus only 13% who did not receive multimodal therapy. Interestingly, on a univariable and multivariable analysis of overall survival, induction treatment, adjuvant treatment, and multimodal treatment did not show any significant differences in overall survival. Similar to the study by Lee et al., a literature review published in 2020 described the majority of patients included as undergoing surgical treatment. Of the patients who had surgery, the majority of those pursued adjuvant treatment. Only 9 patients out of 69 pursued treatment options excluding surgery. Several different chemotherapeutic agents were used in the treatment of these patients with varying degrees of success. In general, although the literature is limited, there is a consensus in favor of multimodal therapy. However, the exact sequence of therapy remains to be defined. In regards to outcomes and survival, the loss of SMARCB1 INI-1 expression portends a poor prognosis compared to those tumors where SMARCB1 expression is retained. This can be seen in higher rates of recurrence, higher rate of mortality, and significantly worse disease-free survival, with SMARCB1 deficient tumors showing 8.5 months on average versus 31.8 months in tumors where SMARCB1 expression was retained. Throughout the literature, SMARCB1 deficient tumors show mortality rates between 37 to 56%, median survival times between 22 to 39 months. Later stage tumors, or T4B tumors, have shown a worse prognosis. These tumors have been described as showing local, regional, and/or distant recurrence, and metastases go to the lungs, brain, pleura, bone, and liver, most commonly. To summarize some key points, SNUC represents a heterogeneous group of tumors of which our understanding is continually evolving. Loss of SMARCB1 INI-1 expression portends a poor prognosis. Thus far in the literature, there is a general consensus in favor of multimodal therapy. However, the optimal sequence of multimodal treatment has not yet been defined. Some authors advocate upfront surgery when resection is feasible, followed by CRT, while other authors advocate induction of chemotherapy, similar to the current treatment of SNUC. If there's greater than 50% response in the tumor to induction chemotherapy, these authors recommend continuing with chemoradiation. However, if there's less than a 50% response to induction chemo, then surgery followed by chemoradiation is recommended. Some future directions include prospective studies to define optimal management strategies and the sequence of multimodal therapy, defining the efficacy of charged particle therapy such as protons or carbon ions versus photons. Additionally, SMARCB1 INI-1 loss could serve as the basis for novel therapeutics, and trials in non-sinonasal SMARCB1 deficient carcinomas are currently underway. Thus far, some have looked at immune checkpoint inhibitors, and others have evaluated tazemetostat, a potent EHZ2 inhibitor. These are our references. And I would like to thank my co-authors for assisting in putting this work together.